Hi, everyone. Thank you for joining us. I'm Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Thank you for joining this journal club. We're really excited to speak to our guest, Dr. Matt Powell. Before we start, of course, obviously, I want to thank ESGO and IGCS for their support of our journal club. In addition, I want to mention a few housekeeping notes relevant to the Zoom platform for today's journal club. We're recording today's discussion, and the recording will be made publicly available. Also, participants with cameras turned on may appear in this video recording, so we ask that everyone please keep your microphones muted so that we can all hear the presentations. If you're having any difficulties or questions, please send a message in the chat, and our technical support team will hopefully be able to assist you. As always, we encourage questions from the audience, so please write your questions in the chat through the course of the Journal Club. So this month we have the lead article titled PARP Inhibitor Maintenance Therapy with Niraparib in Patients with Primary, Advanced, or Recurrent Endometrial Cancer Receiving Dostarlimab plus Chemotherapy. We, of course, have the lead author for that manuscript, Dr. Matt Powell, who's at the Division of Gynecologic Oncology at Washington University School of Medicine. So I'm really always very pleased to speak with him, to see him. Matt, welcome. Thank you for your time. Thank you for accepting our invitation to doing this journal club. We look forward to your presentation. And then, of course, obviously, we'll get on to the questions from our fellows and the questions from the audience. So with that, Matt, floor is yours.
All right, thank you so much, and really appreciate you doing this. It's a wonderful opportunity to highlight this on behalf of all the authors across the world that participated in this important trial. Obviously, we're looking at the inclusion of a PARP inhibitor maintenance therapy in combination with immunotherapy for primary advanced or recurrent endometrial cancer. So this was dostarlimab plus chemotherapy. Next slide. So patients for this trial, what we call Ruby Part 2, basically was the same eligibility as Ruby Part 1. So these were patients with primary advanced or recurrent endometrial cancer. We did have assessment of their MMR status was required prior to randomization. And the patients were randomized in a 2-to-1 fashion with those receiving dostarlimab with chemotherapy, followed by maintenance niraparib with their dostarlimab every 6 weeks for up to 3 years. And then the control arm was a placebo-controlled trial, so placebo with carboplatin paclitaxel every 3 weeks for 6 cycles, and then followed by maintenance placebo of both the oral pill with the niraparib and dostarlimab every 6 weeks. The primary endpoint of this trial was PFS in the overall group and specifically in the MMRP population. Our secondary endpoint was OS in the overall population. And again, the 2-to-1 randomization made this a relatively modest size trial. Next slide. You see the consort diagram showing 291 patients randomized, 192 to the active or the treatment investigational arm, and 99 to the control arm. There are still a few people ongoing. Table 1 shows up rather small in this figure, but relatively balanced, but there was some imbalance within this study. Next slide. And we'll be highlighting some of those imbalances as we go through this. This is the, again, the primary outcome was the progression-free survival in the overall population, showing that hazard ratio of 0.6 with 57% of the patients without progression at 1 year versus 33% in the control arm. The MMRP population, you saw similar improvement in the hazard ratio of 0.63 with 54 or almost 55% at 1 year not having progressed versus 31% in the control arm. Next slide. When we look at overall survival, the differences were really kind of surprising to where there was really not a difference seen statistically between the two groups. with actually the trend favoring the control arm with a hazard ratio of 1.2. And I know we'll be discussing this a lot during this journal club, both in the overall population and the MMRP population, but that similar hazard ratio of 1.2. Next slide. When we look at the adverse events, really not too surprising based on the toxicities that were known with the individual components of adding in niraparib with dostarlimab, with that increase in grade 3 AEs, and then the serious AEs was up to 24.6% in the 4-drug arm. And then I think one of the surprising factors was the amount of discontinuation. You know, we've had quite a bit of familiarity with these medications. Many of the investigators from part 2 were also part of part 1, so had a lot of good immunotherapy experience. Nonetheless, 38% of the patients had discontinuations as part of their treatment in the 4-drug arm versus 11.5 in the control arm. Next slide. So we concluded that the addition of niraparib to dostarlimab maintenance showed a significant improvement in progression-free survival, again, compared with carboplatin paclitaxel alone. There was no observed survival benefit, and actually the trend's in the wrong direction there, and concluded that dostarlimab plus carboplatin paclitaxel followed by dostarlimab maintenance remains really the only regimen to demonstrate significant overall survival benefit versus carboplatin paclitaxel alone. Again, the Ruby Part 1 data. Next slide. And this is our graphic abstract shown for you all that kind of concludes what we've just reviewed. Next slide.
All right.
I don't know if I'll leave that graphic abstract up, or we get to see it. So.
We get to see you, Matt. No, thank you so much, obviously, for the brief presentation. That was really an excellent overview of the study. Congratulations to you and the investigators. Yes, definitely you touched upon a number of items that I think will come up in the discussion. Of course, obviously, there's no difference in the overall survival, the discontinuation rate. So we're really looking forward to hearing more details about those. We will start with our questions from our fellows, and I believe the first question comes from Camila David from Budapest, but who is now here at Houston Methodist. Camila.
Thank you so much, and congratulations for the study and for the presentation as well. So my question is, the control arm performed substantially better than expected compared with historical studies. Looking back, what do you think was the single most important factor contributing to this unexpectedly favorable outcome?
Yeah, great question. So as you point out, this control arm did better than any of the contemporary trials in endometrial cancer. And honestly, I had kind of thought that people would put more pMMR patients on this trial, but there was still a fair amount of dMMR patients. It was a 2-to-1 randomization, making that control group relatively small, as you saw, only 99 patients. And there was imbalance with more favorable prognostic features in the control group, including more endometrioid tumors, less serous tumors. The patients were younger, with less patients greater than age 65. And those were probably the contributing factors that led to this. But we really kind of took a deep dive into all this to understand that. But I think you have a number of factors that contribute to that. We try to balance randomization, but also keep this a very small, efficient trial. And I think that was the hazard here. At the time this trial was designed, it almost didn't move forward because we weren't getting a lot of positive signals for PARP inhibitor in endometrial cancer. And so I think we tried to keep this trial as efficient as possible. And it probably did lead to some of this imbalance. But thank you for the great question.
Thank you.
Matt, also, as you mentioned, in terms of the trial and getting a trial moving forward, and of course, obviously, you have a tremendous amount of experience in running very successful trials. but you mentioned a little bit about like, the signals that we were getting on PARP inhibitors in this setting. Was there ever any point where there was consideration to actually not run this trial?
Well, I think it was, two things. One is the timing. It would have been ideal to have this going on as an additional arm of Ruby Part 1. And we just didn't have enough signal at that point to launch that. To have that direct comparison to a full control arm and contemporarily run with the dostarlimab alone would have been helpful. The signals just weren't enough at that time to warrant that. So yeah, it was this trial almost didn't move forward as we were going through all the preliminary data. I mean, there's a signal there, but it's a small group of patients that seem to benefit from the addition of PARP inhibitor.
Great. So this next question also from Camila, as we have some of our fellows on vacation, as typically is the case in August. So Camila is also going to ask question number 2.
Yes, thank you. I'm asking Chiara Innocenzi's question. So this is the following. The niraparib plus dostarlimab arm had grade 3 or over 3 treatment-related adverse events in 70.7% and adverse event-driven discontinuations in 38.7%, with median niraparib maintenance of only 6.2 months and roughly 1/3 of patients discontinuing niraparib during maintenance. Do you think the short duration of actual PARP inhibitor exposure limited its opportunity to contribute to long-term outcomes? Or would a different starting dose strategy or a design that isolated the PARP contribution have changed your ability to interpret the overall survival signal?
Yeah, I think this is a great question. And, treatment discontinuations during maintenance, in the experimental arm was 25% versus only 5% that were on placebo, which, and this adverse events led to discontinuation in 23% of niraparib, 18% of the dostarlimab patients. And so perhaps more liberal use of dose holds, dose reductions may have helped. And there may be enough overlapping toxicity in this population of, elderly endometrial patients that, it's just too much toxicity and problematic. And as you, correctly point out, with only 6 months of therapy, is that enough? As you know, in ovarian cancer, we're looking at 1 year versus 2 year of maintenance in our high risk patients with ovarian cancer. I think it's difficult to say. You'd say, should we start with lower doses? Should we do something different here to try to make it more manageable? And I don't know that there's going to be enough interest to launch an additional trial until we find a biomarker that really identifies which patients might benefit most here. I don't think this looks like it benefits enough patients to warrant the toxicity.
Thank you
Great.
so
Thank you,
much.
Matt, and Camila for the question. I think still staying on the topic of adverse events, we'll turn over to Ana Conde in Madrid, Spain.
Hello, everybody. Congratulations, Dr. Pablo. I would like to ask about serious adverse events because you reported 46.1% of patients in niraparib and dostarlimab group and a rate of 19.8% of patients with serious adverse events in the control arm. Do you think there are any identifiable risk factors for these severe adverse events? And if we were able to better define the population most likely to benefit from these drugs, could more restrictive eligibility criteria such as higher baseline platelet count or other clinical parameters help to select a fitter population that could receive the full potential benefit of dostarlimab and niraparib while minimizing the adverse events that might negatively affect the survival? Thank you.
Yeah, and a great thought here, and it's certainly worth investigating. We did have the individualized dosing that was found in ovarian cancer with patients' body weight of 77 kilos. Under that, they're starting at 200 milligrams, or if their platelet count was less than 150,000, they're also starting at the lower dose. I think more treatment strategies could be developed to try to manage the efficacy and side effects of this combination. There also has to be probably some investigator bias. As we started to see some results from Ruby Part 1 being quite favorable. We start to see that patients undergoing quite a bit of toxicity, and we had some assurance that checkpoint alone is pretty efficacious in this population by this time, and so perhaps investigators were a little bit easier to take people off trial, knowing the results of Ruby Part 1 and the safety signals there. So moving forward, I think it would probably go beyond weight and platelets as we try to develop toxicity signals. It doesn't seem to be as simple as we think, especially with some of the cross toxicity we have between the two agents. Fatigue's a big factor. Obviously, coming off of chemotherapy, patients are already having quite a bit of trouble. So I think if we do develop a biomarker that shows the best efficacy group for PARP inhibition in endometrial cancer, then perhaps better strategies with more treatment holds and delays and quicker dose reductions may be possible. But thank you. Great question.
Thank you.
Excellent. The next question touches on a point that I think many have questioned. Why niraparib? Why not another PARP inhibitor? So Anna, I will ask this question.
Yes, I will ask this question for my colleague Ezra. Do you think that other PARP inhibitors, such as olaparib or rucaparib, would produce similar outcomes, or could their efficacy and toxicity profiles would lead to different results? Thank you.
Yeah, it's certainly possible. When we look at some of the other trials that have been done and some differences there, one is the Utola trial, which is the French study that's looking at basically carboplatin paclitaxel followed by olaparib alone. And in that trial and in the DOE trial, we're really waiting on a mature OS. And you saw initially from Utola that OS was in the wrong direction for the groups as well. So there was, we had progression-free benefit from the addition of olaparib alone, but the actual overall survival curves, even in the more selected populations, really went the wrong direction. And it's puzzling. And I think, we've seen an early signal on DOE with the OS data from the original presentation, but it was very early, and we haven't seen any updates yet. So it has me concerned that signal may be across PARP, that we're can affect PFS with the addition of a PARP inhibitor and checkpoint. How much that PFS actually is an advantage, and then how it affects OS is a big issue. Toxicity certainly may be a little bit better with a PD-L1 inhibitor, which potentially might have a little less toxicity than PD-L1, but it also may have a little less efficacy too. So adding a PARP inhibitor to maybe a little less efficacious checkpoint inhibitor, may manage toxicity and get benefit. So I think, we have more data that's maturing out of DOE. They were anxiously awaiting to see what, do we see this same signal where we have this problem with OS, I would say. So, but great question.
And Matt, I would presume that given these findings, there's really no enthusiasm to, someone might argue, well, why not repeat this study with a different PARP inhibitor? That would not, I wouldn't imagine, make much sense.
Yeah, I don't think so at this point until the other trials mature. That, again, and probably a better biomarker. I mean, I think HRD we're going to be talking about here in a little bit, but it's just such a small component of endometrial cancer, and it doesn't seem to be as active as a predictive biomarker as we'd like.
Okay, great. So we'll turn over to Chiara Ainio. She will ask the next several questions, actually.
Yeah, thank you very much, and congratulations for the trial. I'm going to start with my colleague Costanza Saponaro's question. And the question is, the control arm had a higher percentage of patients with endometrial histology and lower percentage of patients older than 65 years. lower patients with serious histology and TP53 mutation compared with the niraparib dostarlimab group? And do you think this imbalance could have influenced the results?
Yes, I definitely think so. I mean, as we talked earlier, the control group definitely did better than any of the large recent randomized phase 3 trials. We actually considered kind of a propensity matching from part one to, balance the control groups and kind of combine the trials. And statistically, our statisticians don't like to do that. Even though the trial was performed at relatively contemporary times, there are some changes that you can introduce with that. And I think, really given this OS signal seen, PARP inhibitor didn't seem to add much and was potentially harmful for the population with, certainly with additional toxicity. And again, kind of short of an additional biomarker to identify the right patient group, I think we're kind of stuck. And in that imbalance, that's a problem that we have with a smaller trial using a 2-to-1 randomization and getting a small subgroup. We just can't match the population as nicely as we'd like. Even when you stratify for known risk factors, minor imbalances in the amount of DMMR or the amount of, we know endometrioid cases do different than serous. So all these things, I think, were factors that add to that. Nonetheless, still kind of surprised what happened to the OS and really that lack of benefit and the potential, with the OS kind of going in the wrong direction with the trend. So I think at this point, your question really points out some issues we have when we design trials. So keeping this in mind for future trial design.
Thank you very much.
And we'll continue with Chiara on her next question. And I think now this is having to do with histologic subtypes.
Yeah, exactly. So in the method section, you described a limitation for carcinosarcoma in 10% to avoid overrepresentation. However, we saw in the final analysis that high-risk histological subtypes such as serous carcinoma, clear cell, and undifferentiated carcinoma were approximately 8% more frequent in the intervention group. And so do you think this could have this imbalance could have influenced the results?
Yeah, you point out a very important feature of the trial. Carcinosarcomas, we really had to fight to get them to be eligible for these trials. There was, again, less data available for carcinosarcoma. We're very glad we did because I do think the subset analysis on Ruby Part 1 showed a benefit in this population of adding checkpoint inhibition with dostarlimab. As far as the other subgroups, when you look across serous, clear cell, and undifferentiated, yes, they were numerically higher in the intervention group. That certainly could contribute to the imbalance. We know these patients don't live as long and don't have the prolonged benefit from these therapies as much, and certainly could have contributed to what we saw with OS, given such a small control group. So, yeah, these factors, we've dissected a lot of this and trying to really understand these results, but it's just a factor of the trial that there's some imbalance that happened. But this is certainly one of the explanations. But yeah, thank you for that question.
Yeah. And it's always obviously it's challenging to look at and try to derive the findings from a study onto these like very high risk or rare histologic subtypes. And there's always obviously those questions as to when we're in a tumor board, looking back on these trials, how many patients were carcinosarcoma, how many patients were papillary serous. So yeah, always a challenge. So Chiara, on to your last question.
Yeah, thank you. So my last question is actually from my colleague Eleonora Panizzolo. And the question is, given the PFS benefit, but the lack of OS benefit that you described and the additional toxicity with niraparib dostarlimab, do you think PARP inhibitor maintenance may still have a role in selected molecular subgroups, for example, P53 abnormal or HRD tumors? And which biomarker would you prioritize for future trials to identify patients who may truly benefit from this strategy?
Yeah, I think we'll see a lot of further development in this area. I'm not sure the biomarkers that we currently have are really predictive enough. Even if you focus on HRD and P53 abnormal patients, it doesn't seem to be selective enough. So again, we're talking about a fairly small subgroup of patients. When we think about HRD and endometrial cancer, maybe around 10%. And Utola had kind of a combination of HRR abnormality with P53 mutation to be their kind of best group. Even when we look at that, it doesn't seem to have enough benefit. Now, again, we don't have a dostarlimab alone control arm on Ruby Part 2 to really isolate that signal. So that it's going to be subject to much more analyses and maybe more refinement. I think the tricky part here, and as we point out, the number of patients that probably benefit from the additional PARP inhibitor are probably going to be less than 10%. Is if we do if we do find a selective biomarker. So using this as an unselected population. Again, we saw that the DMMR population from DUO-E, where we did have the single control arm, didn't seem to benefit. So we at least know it's probably in the pMMR population where you'd see a benefit, and that benefit seems to be relatively mild. So another really good, insightful question.
Fantastic. And we'll turn it over now to Nigeria. Kudus, Lawal.
Thank you very much. Thank you, Dr. Powell, and congratulations. My question is closely related to the last one. Given the finding from this trial, would you say the role of PARP inhibitor in first-line chemoimmunotherapy for advanced or recurrent endometrial cancer has been established? Or would you suggest that in future trials we move beyond an all-comers approach towards biomarker-guided designs, such as using of HRD status and molecular subtypes to identify patients that will benefit most from findings of the trial?
Yeah, again, very and building on what we just talked about, the 4 molecular subgroups from TCGA / Promise have given us a lot of information. But as you know, we also have to consider, HER2, ERPR, tumor mutational burden. There's a lot of additional factors. And then now we have the explosion of antibody drug conjugates that give us new biomarkers to be looking at for our patients. And as I mentioned, I think we can conclude from DUO-E and Ruby Part 2 that the DMMR patients don't seem to have any unique benefit from adding a PARP inhibitor and some potential harm. So again, short of a further development of a unique biomarker, we're probably really point out the all-comer approach is probably not the way to go in this situation. But you're right on target there.
Excellent. Thank you, Kudus. And Matt, we're getting some questions from the audience, and this one is from Arthur Hsu, and he's asking, back to your point about carcinosarcomas, you mentioned that you have to, quote, fight for allowing carcinosarcoma to participate. How does this fighting proceed? What pharma or with colleagues, and what is your suggested strategy to get those patients enrolled? Because these patients a lot of times don't have much hope. So again, thank you and congratulations for the study.
Yeah, Arthur, great question. The carcinosarcomas traditionally have not done well at all. And if you think about when you're investing in a trial, and each trial participant is a large commitment for not only the patient, their families, but also the amount of money that's spent on a trial. So that it was a fight to get these patients enrolled. We also felt the patients don't do well, and anything we could do to help their lives be better would be important. And just, the problem with carcinosarcoma, there's just not a lot of trials available, and there wasn't hardly any PARP data for these patients. So yeah, putting these patients on these trials was definitely a battle. But I think, the right thing to do, that we can try to look at all comers and have enough power. The 10% was hopefully give us enough power that at least we could see trends in that subgroup.
Excellent. So we'll turn over now to Germany, Heidelberg University Hospital, Christina Kohler.
Thank you. Coming back to HRD, you already said it's pretty low in endometrial cancer, around 11% rate, compared to ovarian cancer with around 50%. In the previous study, durvalumab combined with chemotherapy improved both PFS and OS. Do you think the findings of this new study showing a benefit in PFS but not in OS could indicate a benefit primarily driven by durvalumab, while the addition of a PARP inhibitor may not be optimally targeted to the broader endometrial cancer population because of the lower prevalence of HRD and the benefit-risk balance of PARP inhibition? Thank you.
Yeah, I think, Christina, you're right on there with your question. And again, the OS benefit we saw with DOE was very immature. And again, now probably almost 2 years later, we don't have an update, and we're really hoping to see one soon. I think that's, concerns me a little bit to what that signal may look like. Hopefully it's really, hopefully there's a good benefit there, but we just haven't seen it yet. And I think we have to come to relations that, PARP actually may be causing resistance. And I think, that's a possibility that, especially in an all-comer population, that we need to carefully consider, is that added toxicity worth it? And, longer-term follow-up data is really needed to help answer this question. But your thought of, really not for all comers when we look at addition of PARP inhibitors in endometrial cancer. We may have lost our moderator there for a second. Do we want to move on to the next question?
Yes, I think Alice, are you there?
Yeah,
Could you proceed with the last question?
thank you. Thank you. So I was wondering, what are your thoughts on the disconnect between progression-free survival and overall survival? I mean, do you think progression-free survival is an adequate surrogate for overall survival for trials in advanced or recurrent endometrial cancer? Or do you think designing trials with overall survival would be impractical since it likely need more patients?
Yeah, again, overall survival really remains our gold standard when powered appropriately. Does obviously require more patients, and crossover and subsequent therapies certainly can cloud our interpretation. For endometrial cancer, we're getting many more options with the explosion of antibody drug conjugates. So unique populations seem to benefit there when you have HER2 or now trope or some of the other things that are out there. So I think there's still situations where PFS may be an appropriate primary endpoint. I do like the dual primary endpoint that we had for Ruby Part 1, which was both PFS and OS. And then kind of really capturing what happens downstream to these patients as far as what subsequent therapies they receive. As these trials happen throughout the world, there's different opportunities to receive other agents. Now, in endometrial cancer, patients didn't used to live very long after their primary therapy. Part of the reason we looked at 2 and 3 years of maintenance on the different trials is most patients didn't make it that long, and now we're starting to see some improvement as we have additional tools to help our patients. It makes it difficult, much more like ovarian cancer, where OS is really nearly unobtainable unless you have a very, very active drug.
Excellent. So, Matt, thank you very much. I think we have one additional question from the audience, and I believe it was Albert Jacob. Albert, I see that you're connected. So do you want to go ahead and ask your question?
I'll ask it. Hi. So I retrospectively, like after the trial's done and everything, what changes in trial design would you consider if you were to redesign the trial right now?
Yeah, I think if we knew what we knew now, I think we would probably have restricted this to a PMMR population. At the time, DMMR, we probably had the least confidence that PARP inhibitor was going to help, and I think it's been confirmed that PARP doesn't add much to the DMMR population. And then, obviously running a well-designed, 4-arm trial that had PARP maintenance alone, dostarlimab alone, and the combination as part of maintenance compared to a placebo group would be ideal to really understand the individual contributions of each medication. But again, the trial was really designed to see if there was a signal there. We were compromising and knew this probably wouldn't be definitive, but wanted to see if perhaps there were subgroups that were going to be benefiting. But I don't think that we'll see further development of dostarlimab and niraparib moving forward unless there's a robust biomarker, and then we'd probably be looking at smaller group, a smaller focused trial if that were to be developed. But great question, Albert.
Great. And Matt, as a concluding question, moving forward, setting the tone, there would not be a reason for any patient to be on this combination outside of a clinical trial in the standard setting. Would you agree with that?
Yeah, I think so. I mean, the people say, well, what if they have a BRCA mutation? And we still don't have enough evidence even in the BRCA patients, I think. It's a compelling argument, and it is, fairly rare. A couple percent of these patients will have a BRCA 1 or 2 gene mutation, either somatic or germline. I think that at this point, yeah, outside of a clinical trial, I'm not endorsing the 4-drug combination.
Excellent. Well, Matt, thank you so much for your time, for your discussion. I want to thank you for, again, allocating the time to sit with us, discuss this article. Of course, obviously, as always, I want to thank the fellows for bringing their questions to the Journal Club, and for everyone that joined and submitted their questions as well. I also want to invite everyone to the September Journal Club to discuss an article titled FIGO IGCS Statement on the Efficacy of Topical Treatments for High-Risk Human Papillomavirus in Preventing CIN3+ Lesions. That will be with Dr. Rene Pareja. So with that, we'll conclude. And Matt, once again, thank you so much. Hope everyone has a great day and a great rest of your summer.
Hey, thank you so much. This has really been an honor to participate in such an important endeavor. Thank you.
Thank you.